Hello and welcome. Firstly, I would like to acknowledge that we are gathered here today on the lands of the Wallumattagal people of the Darran Nation. I pay my respects to elders past and present, and I would like to extend that respect to everybody here today. I'm Dr. Kathy Smiley, the current lead at MQ Cardiology Outpatients. Today we are discussing how to have a healthy heart. Even with COVID over the last few years, the leading cause of death remains unchanged. Coronary artery disease number 1, followed by dementia and stroke. These three share a number of commonalities. Genetics aside, a large part of this risk for these problems is driven by modifiable, treatable risk factors, and the earlier the better. So when you look after your heart, you're also looking after your brain, and how you live your life in your middle age will help determine the sort of life you have in your older years. So I'd like to introduce our first speaker, Dr. Darran Foo, a New South Wales University graduate and Fellow of the Royal Australian College of General Practitioners. Darran is actively involved in an integrated care program here at MQ Health. His research interests include how we can build more patient-centred integrated health systems that are complemented by digital health technologies. Darran is going to explore the different ways we can manage and reduce cardiovascular risk.
Thank you, Kathy. All right. Good afternoon, everyone. So my name's Darran. I'm one of the GPs here at MQ Health, and I'm also quite involved in our integrated care program and also teaching a lot of our medical students and GP registrars. So today I'll be talking about heart health checks and what that really involves when you go and see your GP about heart health check is really talking and exploring about different ways to manage and reduce your cardiovascular risk. So before we get into it, I thought what we should do is really define what we mean by cardiovascular disease, because I think sometimes when people talk about cardiovascular disease, we may think about different things. So in terms of cardiovascular disease, yes. What is cardiovascular disease? So in terms of cardiovascular disease, it really is a broad term that covers many diseases that involve the heart and really any other blood vessel in your body. So that could be a wide variety of things, but for most intents and purposes in Australia, when we talk about cardiovascular disease, we're mainly referring to two major organs, I guess, and that would be your heart, and also your brain. And within the heart, when we talk about cardiovascular disease, we tend to refer mostly to coronary heart disease or coronary artery disease, also known as ischemic heart disease. And these could come in the forms of having a heart attack or in the form of getting angina. And also the other portion of cardiovascular disease that's involving the heart is also heart failure. And when we talk about the brain and what's involved in cardiovascular disease, we're mainly referring to a term called cerebral vascular disease, but really this is a term referring to different types of strokes. Of course, there are many other diseases that fall under the umbrella term of cardiovascular disease, but for most intents and purposes, when we talk about cardiovascular disease, we're referring to essentially things around heart attacks, heart failure, and strokes. So when we talk about your risk of cardiovascular disease, then most of the time we'd be referring to, reducing your risk of getting heart attacks, getting angina, getting heart failure, and reducing your risk of getting a stroke. Okay, so it's actually been quite a success story from a public health perspective and a preventative care perspective in terms of the number of deaths that we see from cardiovascular disease. And as you can see from the graph, cardiovascular disease is an umbrella term for both coronary heart disease and cerebrovascular disease. So since its peak in kind of the late 60s in 1970, due to multiple preventative and public health measures, we have seen the death rates of cardiovascular disease drop quite dramatically over the last few decades. And this is a combination of things like smoking cessation campaigns, campaigns to such as including the heart health checks as part of our Medicare billing system and seeing your GPs, and also campaigns around healthy diet and lifestyle and exercise. And so it's really been quite a significant reduction in death rates over the last couple of decades. And we've seen this across many of the developed nations over the world. So, what are your risk factors for cardiovascular disease? So, as Kathy alluded to earlier, there's some things that we can't change. So these are things like your age, your gender, and things like your family history, your genetics, and your ethnicity. But there are also others that you can influence. And this includes factors such as whether you smoke, how much you drink, and how often you drink. Issues around your diet and having a well-balanced and healthy diet. And we will have a speaker, Valentina, talking a lot about diet later in the program. And how much physical activity you do, so how much exercise you get in your week. And these influence things such as your blood pressure, the level of cholesterol in your body, what your weight is, and also your risk of getting diabetes and whether you have diabetes or not. And these are all factors that come into play when talking about managing or reducing your risk of getting cardiovascular disease. There are some lesser known risk factors. This includes things like mental health conditions such as depression, or in groups of people who have chronic conditions that result in chronic inflammation. So you have all these risk factors and they all come into play and interact with one another. And assessing your risk is not as simple as if you have one risk factor, for example, if you smoke, then you're at high risk of cardiovascular disease. But really, it's important to look at risk factors in combination and not in isolation. So what that means is you may want to look at all your risk factors together and decide on how that impacts your cardiovascular risk. And when you go and see your GP for a heart health check, this is essentially what you will discuss with your GP. You discuss issues around the modifiable risk factors, so risk factors that you can change, and how you can manage the risk factors that you can't change. There's some tools that we like to use, and one of them includes the absolute cardiovascular risk calculator. And this is a very useful tool, and you're able to put in a bunch of your risk factors, both things that you can change and others that you can't, into this algorithm, and it spits out a risk calculation for you. And as GPs, we use this a lot when we discuss cardiovascular risk with our patients, and it helps us to decide how we best manage someone's cardiovascular risk. For example, whether we decide to put someone on medication for their blood pressure or their cholesterol, or whether we decide to not do that and focus a lot more on lifestyle changes such as diet and exercise. And often it's a combination of both for certain groups of people as well. There are other types of calculators. The Heart Foundation has what we call a heart age calculator, and it does take into account most of the similar factors that you put in your absolute cardiovascular risk calculator. And this can be found at the Heart Foundation website, and it gives you an estimate of what your heart age is and how that compares with your actual age. And so those are some of the tools that we can use to calculate your risk. And then we make a decision on how we manage someone's risk. And that includes things like changing your diet, how much you exercise and other lifestyle factors, and whether we decide to put someone on medications such as medications to lower your blood pressure or medications to lower your cholesterol. So, what can you do to reduce your cardiovascular risk? There's some key things that would apply to others and some that may not apply. But the general rule is that smoking is a big risk factor, and if you're smoking, stopping smoking can significantly reduce your cardiovascular risk. And drinking in moderation. So you don't have to cut out drinking entirely, but drinking within what is recommended in the Australian alcohol guidelines. And this is updated from time to time, and at the moment where the current guidelines is recommending not to have more than 10 standard drinks within the week. And this would vary depending on if you have other chronic conditions or liver conditions, for example. Having a healthy and well-balanced diet also significantly impacts your cardiovascular risk and can impact the level of cholesterol and your blood pressure. And having regular physical activity. And there are some guidelines published by the Department of Health, but generally we want people to have at least half an hour a day of moderate intensity physical activity. Maintaining a healthy weight, which is a combination of all of these things essentially, and getting your GP to monitor your blood pressure, cholesterol, and assess your diabetes risk on a regular basis. Looking after your mental health and stress levels are very important, as these can also be risk factors for cardiovascular disease. And in some people, we use medication to manage cardiovascular risk. Not everyone needs medication all the time, but in some groups of people, especially for those who are at high risk of cardiovascular disease, when we use some of those calculators, and in people who already have a history of a heart attack, or you've had a stent or a bypass surgery, or if you've had a stroke, those groups of people automatically have cardiovascular disease already. So we want to manage them a little bit more aggressively with medication. And there's also roles for aspirin and other anti-clotting medication, and this includes sometimes for people who are at high risk of cardiovascular disease. But this can vary from person to person, and it's best to talk with your regular GP about this and whether you want to involve a cardiologist. Compliance with medication is very important, and it's good to check in with your GP from time to time, especially if you have any issues with side effects that stop you from taking your medication regularly, and having a discussion on how you can manage that. And sometimes it can be hard to stay motivated to take your medication regularly, especially if you're taking many medications at one go. And so you're not alone. Lots of people to help in your journey of managing your cardiovascular health, heart health, and cardiovascular risk. And this includes many team members of your healthcare team, your GP, your cardiologists, exercise physiologists who can help with healthy weight and physical activity, dietitians, psychologists, and physiotherapists, and who all are available here at MQ Health and work as a team to help improve your heart health and optimize your cardiovascular risk. And that's all I have. Thank you very much.
Thank you very much, Darran. I'd now like to introduce Dr. Dhruv Nayyar. He is a consultant cardiologist here at Macquarie and elsewhere with a subspecialty interest in advanced cardiac imaging, preventative medicine and preoperative cardiac risk assessment. He has presented at national and international conferences and published in peer-reviewed journals. Dhruv will discuss the various investigations we use to diagnose cardiac problems.
Thank you for that introduction, Kathy. So, an outline of my talk, I'll be speaking about when you should come and see a cardiologist, common conditions that we treat in clinic, and investigations that your friendly cardiologist may arrange. And I have no relevant disclosures for this presentation, and this should not be used as personal medical advice. So when should you come and see a cardiologist? So it's for symptoms such as chest pain, difficulty breathing, dizziness, palpitations, fainting, or lower limb swelling. So these are the common things that we see every day. Also, we often see people for a preventative health check for some of the risk factors that Darran was discussing earlier. For example, diabetes, high blood pressure, high cholesterol, if you are a smoker, or have a family history of heart disease. And in some cases, your surgeon or anaesthetist may recommend that you have a cardiology review before having surgery. So common conditions that we treat in clinic are coronary artery disease, heart failure, arrhythmias or irregular heart rhythms, valvular heart disease, that's either narrow or leaking heart valves, high blood pressure and high cholesterol, just to name a few. So, common initial tests that your cardiologist may arrange might include some of these, and I'll go through these one by one. And this is not an exhaustive list, but these are the common ones. So, a Holter monitor. Now, this may be worn for usually 24 or 48 hours, but in some cases it might be longer. And this is a monitor that's used to investigate symptoms like palpitations or the sensation that your heart might be fluttering or beating fast. If you're feeling dizzy or if you've actually fainted, okay? And the common findings that we might see on a Holter monitor would be a fast or slow heart rhythm, pauses, or extra beats that you might have heard of as being called ectopics. And sometimes in a Holter monitor we don't find anything wrong, and that can be very reassuring that we've ruled out any serious heart rhythm problems in that monitoring period. Another common non-invasive investigation that your cardiologist might order is a transthoracic echocardiogram, or what we call an echo. And this is essentially a heart ultrasound that's done for you. So these are a few videos showing a normal healthy heart. So the top two chambers that my cursor is pointing on at the moment are the pumping chambers of the heart, or the ventricles. And the bottom chambers are the atria, or the filling chambers. And these are the valves opening and closing with each heartbeat, as you can see. And we can put color on these heart valves to detect either narrow or leaking heart valves. So this is an echo. Yeah. And we can diagnose a number of abnormalities on an echo. For example, this is an example of a heart that's not beating very strongly, and that's because this person has an irregular heart rhythm. On this video, we can see the blue jet of color, which is indicating a leaking heart valve. So we might organize a stress test or a stress echocardiogram, and that's when you will be hooked up to an ECG monitor, and then you will usually walk on a treadmill. And we will be recording your ECG in the various phases of exercise and then towards the end of the study as well when you stop walking. So what we see here is a heart beating nicely at rest, and then after exercise you expect that the heart is beating more strongly. And again, this is a nice, normal, healthy heart. So there are other tests that your cardiologist can order or suggest that you have. And in recent years, the coronary calcium score has become quite popular. This is a non-contrast CT scan, and it's quite useful in patients that don't have any cardiac symptoms, they don't have chest pain or shortness of breath, and they're deemed to be at low to moderate risk and that can be judged using one of the risk calculators, as we've heard about earlier today. Now, for any clinicians that might be listening, the coronary calcium score is very useful in certain settings, but it's not very useful, for example, in patients that have symptoms such as chest pain, because even a low or normal calcium score doesn't necessarily exclude coronary artery disease. It's also not particularly useful in patients that have known coronary disease, for example, stents or bypass already in the past. So this is an example of a CT scan and a coronary calcium score, and you see the plaque here in one of the major arteries, the left anterior descending artery. Sorry about that, not sure what happened there. And then once we are able to get the patient's calcium score, they can be plotted on a graph respective to your age cohort, and you have a sense of where you sit compared to patients of the same age. Another useful diagnostic tool for detecting coronary artery disease is a CT coronary angiogram. This is a CT scan which does require contrast, and so it is a little bit different to the calcium score, and it does give us these very nice pictures of the heart, as you can see this 3D reconstruction of the heart, and it gives us an idea of if there are any narrowings or blockages in the heart vessels. So this is a diagram illustrating atherosclerosis. So this is a normal artery, and this is an artery which has atherosclerosis or plaque in it. And growth and rupture of the plaque can then lead to a heart attack. So these are some examples of CT scans showing plaque in the coronary arteries, as you can see where my cursor is pointing. And if you were found to have plaque such as this on your CT coronary angiogram, your cardiologist would discuss with you regarding further management and investigations as required. I just wanted to talk briefly about an interesting and important study in this field, and this might be relevant to some of the clinicians that are listening in, but this was called the Scott Heart Trial, and this compared approximately 2,000 patients who were either in the CT coronary angiogram arm or the standard care arm, which was usually an exercise stress test. And as you can see on this Kaplan-Meier curve, we basically found that the investigators found that death from coronary heart disease or non-fatal myocardial infarction was lower in these patients at 5 years of follow-up who were in the CT coronary angiogram arm versus the standard care arm. And just discussing briefly about some recent guidelines comparing non-invasive imaging versus, for example, CT, and comparing that to a stress test, and both are considered to be essentially equivalent and very appropriate in different scenarios. There are, however, some scenarios where, for example, CTCA may be less preferable to a stress test, and your cardiologist would be happy to discuss that with you. Thank you.
Thank you, Drew. That was a nice outline of all of the basic tests you may or may not have, depending on what your problem is. Our last speaker is Ms. Valentina Duong. She's an accredited practicing dietitian. She specialises in cardiac health, weight management, body recomposition and mental health. As an international powerlifter, she understands the importance of nutrition in improving performance, productivity and mental health. She's going to discuss this as well as how diet impacts cardiac health and some diet strategies.
Thank you, Kathy. Today I will be talking about healthy eating for heart health. When it comes to heart health, there is so much that we can do in our everyday lives to reduce our risk of developing cardiovascular disease. Today, I'll be running through the key nutrients that impact your heart health, how our diet impacts our blood markers, and how you can adjust your dietary pattern to strengthen your heart. So the 3 key nutrients that we'll be talking about today is the type of fats, the amount of salt, and the amount and type of fiber you should be having to have a healthy heart. The 3 blood markers to consider are LDL cholesterol, HDL cholesterol, and triglycerides. HDL cholesterol is the helpful cholesterol that helps protect us against heart disease, whereas LDL cholesterol and triglycerides in excess can increase your risk of heart disease, heart attack, and stroke. Dietary fats that negatively impact heart health are saturated fats and trans fats. Saturated fats increase LDL cholesterol, and in the average Australian diet, we have an excessive amount of saturated fats, from processed meats, red meat with visible fat still on it, so untrimmed meats, butter and cream, which are also found in cakes, biscuits, pastries, chips, and also saturated fat is found in palm oil and coconut oil. When it comes to dairy products, they also contain small amounts of saturated fats, but it's important to remember that they also contain many important nutrients that help support heart health, things like protein, calcium, phosphorus, and other important nutrients. So the Heart Foundation recommends that we actually continue to include dairy in our diet, and research has shown that dairy has a neutral impact on our heart health due to it having small amounts of saturated fats, but also many other key nutrients. It's recommended in the Australian Dietary Guidelines that you continue to have 2 to 3 serves of dairy per day, with 1 serve of dairy looking like 1 cup of milk or 1 cup of yogurt or 2 slices of cheese. Another fat to consider is trans fats, and these negatively impact our heart health because they increase our LDL cholesterol and decrease our HDL cholesterol. So trans fats are generally found in hydrogenated vegetable oils, and these are predominantly used in takeaway shops to make fried foods, or then used commercially in baked goods and pastries to give them that crispy texture. We're very fortunate here in Australia that we use a very minimal amount of trans fats in our processed foods, and the majority of us obtain less than 1% of our daily calories from trans fats. So our main focus should be to reduce our saturated fats where possible, and to reduce our intake of takeaway foods to reduce our intake of trans fats. The dietary fats that can be really helpful for heart health are polyunsaturated fats and monounsaturated fats. A low-fat diet isn't necessary for heart health. In fact, polyunsaturated fats and monounsaturated fats help improve our heart health by decreasing our LDL cholesterol. On top of that, polyunsaturated fats, including omega-3 and omega-6, also decrease our triglycerides, and they can be found in things like oily fish, sunflower seeds, walnuts, flax seeds, and canola oil. Monounsaturated fats, on top of decreasing LDL cholesterol, also increase that healthy HDL cholesterol, and they can be found in things like olive oil, peanut and canola oils, avocado, nuts and seeds. So what we want to be doing is replacing our saturated fats and trans fats with the heart healthy polyunsaturated and monounsaturated fats. So another thing to consider as part of the polyunsaturated fats are the omega-3 fatty acids. They help reduce our risk of heart attack and stroke by lowering blood triglycerides and cholesterol, reducing our blood pressure, and lowering our risk of blood clotting. So it's recommended that we actually have 2 to 3 serves of oily fish per week, with 1 serve of fish being 150 grams of cooked fish. And what that might look like is 1 deck of cards, or it can look like the palm of your hand and the thickness of your palm as well. So the best sources of oily fish are mackerel, salmon, tuna, and herring, but you can also find plant-based omega-3 fatty acid sources in walnuts, linseeds, soybean oil, and canola oil. You can also obtain some omega-3 fatty acids from supplements. However, we do want to take a food-first approach because the foods that are high in omega-3 fatty acids like oily fish also contain important nutrients like protein and iron, and the plant-based sources of omega-3s like nuts and seeds also contain so much fibre and zinc. As Darran talked about earlier today, our blood pressure is a key factor for our heart health, and the main dietary factor contributing to high blood pressure is excessive salt intake. Excessive salt intake increases our blood pressure, which increases our risk of stroke, heart disease, and kidney disease. The Australian Dietary Guidelines recommend that we have less than 5 grams of salt per day, which is less than 1 teaspoon of salt daily, which is also equal to 2,000 milligrams of sodium. So on average, Australians eat almost double that of 9.6 grams of salt daily. When we think about salt, we often think about the salt that we're adding to our cooking or at the dinner table, but in fact the majority of our salt intake comes from processed foods, with 75% of our salt coming from processed foods. So that means that we want to be reducing our intake of processed foods and increasing our intake of whole foods. We can reduce our salt intake by reducing these highly processed foods, but also using salt reduced or no added salt spreads, sauces, and canned foods. As you can see here on the Heinz baked beans, there are reduced salt alternatives, and similarly in tomato sauce and barbecue sauce, you can choose lower salt alternatives. We can also remove salt at the table and reduce the amount used in cooking, and replace that taste by using herbs, spices, lemon, pepper, garlic, and onion. It's important to remember that your taste buds do change over time, and to be patient with yourself as your taste buds adjust to the lower amount of salt. Another key nutrient that can impact your heart health is fibre. So we all know that fibre has a great impact on our gut health, but it can also improve our heart health by lowering our total and LDL cholesterol. So there are 2 types of fibre that I want to talk about. The first one being insoluble fibre. So this is the fibre that's found in whole grains and wheat cereals, so things like All Bran and Fibre One. This is great for keeping us regular and helping with bowel health. But when we're thinking about heart health, we want to be getting our fibre from soluble fibre. So these are things like fruit and veggies, especially the skin. So if you can keep them on, then that's going to give you more soluble fibre. Barley and oats, legumes and beans. So soluble fibre, having 5 to 10 grams of it each day, can actually reduce the amount of cholesterol absorbed by your body. It also keeps you feeling fuller for longer and improves blood sugar control. And all of these things in combination can help you maintain a healthy weight. So in terms of total fibre, we want to be aiming for between 25 to 30 grams of fibre per day. Another nutrient to consider is plant sterols. They have been found to reduce cholesterol by 10 to 15% when taken with meals. They are naturally occurring in nuts, legumes, fruits and veggies, breads and cereals, but you can also find them in sterol-enriched foods, so things like Proactive and some types of cheeses as well. So it's recommended to have an intake of 2 to 3 grams of plant sterols per day to help reduce your total cholesterol. Please note that above 3 grams, there is no additional benefits in reducing your cholesterol levels. So when it comes to the best preventative diet for heart health, it is one that is rich in fruits, veggies, whole grains, nuts, fish, poultry, and olive oil, and one that is low in sugar, salt, highly processed meats, refined carbohydrates, and unhealthy fats. Heart-healthy dietary patterns are linked to a 31% lower risk of heart disease, 33% lower risk of diabetes, and 20% lower risk of stroke. So there are many dietary patterns that meet this, but one great example is the Mediterranean diet. As you can see at the base of that pyramid, the Mediterranean diet is based on whole grains, fruits and veggies, so whole foods. It contains dairy foods, eggs, olive oil, fish, seafood, and poultry. And then in moderation and infrequently in small amounts, it contains meats and sweets. So in summary, we want to enjoy plenty of plant-based foods such as fruits, veggies, whole grains, legumes, beans, nuts and seeds. And we want to be replacing our saturated and trans fats with polyunsaturated and monounsaturated fats. We want to limit salt and added sugar where possible. Thank you so much for having me. I'll pass it back to Kathy. Oh,
Thank you, Valentina. That was a really comprehensive outline of diet. That was terrific. And before we move on, I'd just like to again thank all of our presenters today for giving us lots of information to start a good discussion.
We are eyes. We never stop searching. We are hands, warm like blankets and still with certainty. We are ears, loud or soft, we always hear. We are feet, carrying us on your journey. We are arms, always ready to fight. We are the fuel that supports body and mind. We are the brain. We'll never give up trying to understand. We are the heart. We beat with one purpose. In an Australian first, MQ Health integrates world-class clinical care, teaching and research with one goal in mind: to deliver the best for our patients and our community. We are MQ Health.
Right, so we're going to just go through some of the questions that have been coming through. The first one is a pretty, I suppose, obvious question, but maybe we didn't answer it, which is, what's the deal with gender? Why do women and men have different risk? Darran or Dhruv, would either of you like to comment on that?
Dhruv, do you want to go?
Yeah, sure. So I guess, there is definitely a difference in risk between men and women, and part of that may be hormonal, and that can change after menopause, and the risk for women does go up after menopause. And look, perhaps part of it may be lifestyle based as well. One of the other important points in terms of differentiating between men and women is that in terms of symptoms of coronary heart disease or cardiovascular disease, women can sometimes present in ways that are quite different to men, or ways that we might have heard about previously in the media, and sometimes it may be not recognized early, and so that's something that we have to be mindful of and educate everyone about, that the presentation between men and women can be quite different of heart disease.
Yeah. I think it's also a reasonable comment to say that whilst women may have less heart disease when they're younger for hormonal reasons, they catch up with the men in terms of the incidence of heart disease as they get older, so we can't be too complacent about that.
Yeah.
All right, and this is a very specific cardiac question. Somebody would like you to explain the difference between a pacemaker and a defibrillator.
Okay, sure. So both are cardiac devices that need to be implanted by a subspecialist cardiologist called an electrophysiologist. They both require a small box being placed under the skin and then leads being inserted into the heart. A pacemaker is usually used for people that have a slow heart rate or pauses to help the heart beat more regularly. A defibrillator is used for quite different reasons, usually a weak heart, and that can cause dangerous heart rhythms, and in that case, if your heart goes into a dangerous rhythm, a defibrillator can generate a shock from inside and essentially shock your heart back into a normal, safe rhythm.
All right, now this is a question that I get all the time in the practice. Should I try dietary changes to reduce my cholesterol levels before trying medication, such as Crestor or Lipitor, or do both?
Yeah, I'll answer this question. I think that comes back to depending on your level of risk, as I had mentioned in some of parts of my talk. I think the answer here is that there's no single answer that's just going to be the same for everyone, and I think the answer here is going to be quite individual based on your circumstance and what risk factors you have. Certainly for certain groups of people who are at very high risk of having cardiovascular disease, we'd want to do both. And there will be groups of people who are not as high risk, but for whatever reason have a little bit of a high cholesterol. We may decide to opt for a non-pharmacological, so non-medication route of managing your cholesterol, such as some of the dietary changes that Valentina spoke about, and then also involving things like increasing your amount of physical activity and exercise, trying to manage your cholesterol that way. So it's a combination, I think, the answer.
No, excellent answer, Darran. And just to add to that, I think in that exact space, the CT imaging can be extremely useful. So in a patient that has high cholesterol but a normal calcium score, a calcium score of 0, then I generally do have more of a discussion about lifestyle-based options initially, versus a person that might have a calcium score of 100 or even 1,000. Then the guidelines are clearer that we should be having a more detailed discussion about starting medication therapy, of course in conjunction with the lifestyle modifications.
Very important to do both, because there's still always added benefits on top of medication if you can also approach the dietary issues. So I might move on to a specific dietary thing. You talked a lot about different diets. Just one comment I was going to make is for people who need to get calcium but also need to watch their weight, low fat milk and yogurt still has the same amount of calcium, so you can still do that if you're also worried about your weight. I've had several patients I've seen lately where they, because they've seen various celebrities doing this, have gone on to a high-fat, low-carb diet with great success in losing weight. But they come to me because their cholesterol, and I had one yesterday, her cholesterol had gone from 5.5 to 8.5. Would you like to comment on that particular diet?
Yes. So a keto diet or a carnivore diet, one that is very high in red meat and processed meat, can absolutely shoot up your total cholesterol levels because it is very high in the saturated and trans fats. So I think that when it comes to weight loss, it is only one measure of health, and not all weight loss is healthy. So using a method that is as drastic as that can absolutely impact your heart health. And it's also important to consider, how sustainable is this option? Can you continue to do this for a long time? Because what I find when patients are going on diets like that is they may lose the weight rapidly, but they regain the weight rapidly as well, which again is another risk factor for your heart health. Yeah, so absolutely I would recommend speaking to a dietitian and, seeing how you could have a balanced, variety of foods in your diet and still reduce your cholesterol levels.
The original diets, as I understand it, that were done and medically tested to look at this type of diet did contain a much higher proportion of unsaturated fats in them. And maybe that's part of the problem, that there's been an overemphasis on fats like meat and processed meat and cheese rather than our healthy fats, which you talked about, fish and seafood and nuts, etc. Would that be fair comment? Or
Yeah, absolutely. If you were very keen to go down that route of lower carb, higher fat diet, considering yes, olive oils, canola oil, and pulling back on things like really fatty meats or even coconut oil, which can be really high in saturated fats. I think everyone thinks coconut oil is very healthy, but it's actually very, very high in saturated fats. Not something we want to be using regularly.
Yeah. Thanks for that. I had one last question. I suppose this has been in the media, so people are always interested in things that they've read in the newspaper. Would anyone like to comment on lipoprotein a?
I have no clue.
Oh, I guess, all right, that might be thrown back to me. Look, it has been in the newspaper, so this is a type of fat that isn't routinely tested for. So if you went to see someone like Darran, he wouldn't do this test, he'd just do your normal cholesterol profile. It's been in the newspaper because we do know it's associated with a higher risk of early onset heart disease. But up till now, we haven't really had any good ways to treat this, and I think it's crept into the newspaper because a treatment is approaching. So if anyone, the question is, well, do I need to be worried about that? In a practical sense, the people that we would normally check this in would be people who have very early onset heart disease or a family history of very early onset heart disease. So it's fairly selective. We do not need to test this in everybody. All right, I have...
Because it's still, to an extent, in the research sphere.
That's
like
right,
what you're
yes.
saying,
So it's for a specific group of people. I have a question for you, Drew.
Yes.
Another thing that gets commonly asked when we see patients after they've done their treadmill test and they've performed very well is, so I'm fine, I won't have a heart attack, will I? Would you like to comment on that?
Okay, yeah. Great question, Kathy, and absolutely, we get asked this question every week. Look, the treadmill stress echocardiogram is a test that's been used for many years, and even before that a treadmill stress test, which did not have the echocardiogram component to it. The stress echocardiogram is a very useful test. There's no radiation dose, as is there, for example, in a CT coronary angiogram or a formal invasive coronary angiogram. This treadmill stress echocardiogram gives us very good information about the patient's exercise capacity, their blood pressure response to exercise, and their fitness levels. Of course, it's not a fail-safe. I mean, a normal stress echocardiogram, yes, is reassuring that perhaps there is no severe blockages or severe coronary artery disease. But yeah, it's not an absolute guarantee, but certainly it is a very useful test. And look, in cases where, for example, somebody may have a borderline test or a normal test but still having symptoms, then a CT coronary angiogram is certainly very useful and worth discussing with your cardiologist, because that gives what we call an anatomic assessment of your heart arteries, and we can actually see if there are any blockages or not.
All right. I think I've come to the end of my questions, so we might just wrap things up there. And again, thank everybody for their participation and for sharing their knowledge.
Thank you.
Thank you.